Hello everybody, I'm Geertrui Mertens and I will do a small talk about the management of febrile neutropenia. Here you will find an overview of my presentation. I will discuss the following topics. I will start with the definition, of course, some risk factors, the place for primary prophylaxis, the management, and I will end with some take-home messages. Febrile neutropenia is defined as an oral temperature of more than 38.3 degrees or a temperature at least of 38 degrees sustained over 1 hour period, and there is an absolute neutrophil count of less than 1.5 or expected to fall below 1.5. Despite major advances in prevention and treatment, febrile neutropenia remains one of the most frequent and serious complications of cancer chemotherapy. It's a major cause of morbidity. It results in delays of the therapy, in the need of dose reduction, in hospitalization, contact with caregivers, and unfortunately, it still results in a significant mortality. Most chemotherapy regimens are associated with 6 to 8 days of neutropenia. The incidence is 8 cases per 1,000. The morbidity is around 20 to 30%, so it's significant. The mortality is around 10%, so very significant. Several risk factors are responsible for increasing the risk of febrile neutropenia. And of course, there is a clear relationship between the severity of neutropenia and the type of chemotherapy. You can divide chemotherapy in 3 groups. You have the high-risk group, more than 20%. Then you have the low-risk group, less than 10%. And in between, there is the intermediate risk group. Age is another risk factor. Older patients have a higher risk of febrile neutropenia. Advanced disease, history of prior neutropenia, no antibiotic prophylaxis, no granulocyte colonic stimulating factors, mucositis, poor performance status, underlying cardiovascular disease, and the presence of comorbidities. And the risk of febrile neutropenia and its complications increase when one or more comorbidities are present in a patient, and this will be very instrumental in deciding which patient should receive primary prophylaxis. You can estimate the mortality based on the MAS score, and the MAS score or index can be used to identify whether your patient is a high or low risk. When the score is less than 21 points, so it's based on a point system, your patient is a high risk. And you see when the MAS score is less than 15, there is a mortality rate of 40%. Finally, in the case of febrile neutropenia, prognosis is worse when there is a gram-negative bacteremia and when there is a presence of a focal site infection as a pneumonia or cellulitis or etc. So we continue with the topic primary prophylaxis. Several meta-analyses indicate that primary prophylaxis with growth factors reduce the risk of febrile neutropenia by at least 50% in patients with solid tumors. And most guidelines use this flowchart where they recommend the use of growth factors when there is a risk of more than 20%. It's important to consider the patient's age and particularly when there are any comorbidities. And with most of the chemotherapy, the risk of febrile neutropenia is maximal during the first course. So that's important. It makes sense to recommend primary prophylaxis rather than resort to secondary prophylaxis. And there I want to emphasize that the use of secondary prophylaxis is indicated in the group of patients with a curative intent, where you want to avoid dose reduction or delay of chemotherapy. So the dose and route of application of growth factors depends on the local guidelines of the country or hospital where you work. So very briefly summarized, there are 2 groups. here you can see the dose. They are very well tolerated. The most common side effect is minor or moderate bone pain. So we end up with the management. It's vital, it's very important to educate outpatients, to monitor their symptoms, and you have to provide clear instructions what they have to do when there's a problem, when there's fever. But when the patient presents in hospital, you have to look to the medical history, type of chemotherapy, prior prophylactic antibiotics. Was there a steroid use? Was there a past positive culture? Of course, physical examinations. You have to do the routine investigations. And it's very important that you give the first dose of antibiotics within 1 hour after admission. You have to be aware that the patient is stable. And as we already discussed before, you can use the MASC index or score to estimate the risk. So patients who are at high risk when the score is less than 21 should be admitted on a broad spectrum antibiotic therapy. And depending on the focus, you can associate vancomycin or an antifungal therapy. And when there is a very severe sepsion, you can associate granulocyte colony-stimulating factors or growth factors. So when the score is more than 21, it's a low-risk group. When there is no underlying infection, no acute leukemia, no organ failure, no pneumonia, no catheter infection, you can start oral therapy in some cases. And a recent review has concluded that it can be used safely. In a small group, you can use the oral antibiotic therapy. So I will end with some take-home messages. Febrile neutropenia is an important problem. It is observed in 1% of patients receiving chemotherapy. The morbidity and mortality are significant. You have to think about primary prophylaxis. It's very important. And the MASC score can guide you in your management. Thank you for your attention.